Hi, everyone. It's Edwin Rutsch, Director of the Center for Building a Culture of Empathy. And today I'm here with Amber Bennett-Weston. And Amber, you're a postdoctoral research associate at the Stoneygate Centre for Empathic Healthcare. Would you like to say more by way of introduction, maybe something about the center that you're working at?
Yeah, thank you. So yes, I work at the Stoneygate Centre for Empathic Healthcare. We're based in Leicester in the UK, and our mission is to improve patient outcomes by embedding a culture of empathy within healthcare and also importantly healthcare training. So for undergraduate and graduate students.
And you do training, right? That's one of your backgrounds is training, is that right?
Yeah. So we deliver training. So at the moment we're based in a medical school, Leicester Medical School, and we're teaching sort of medical students. We've added specific interventions into the medical curriculum to enhance medical students' empathy. Eventually, our goal is to expand across different healthcare professions, and we also deliver training for qualified healthcare professionals as well.
Okay, so we wanted to talk about the definition of empathy. There's seems to be a lot of confusion out there, and you'd recently with Jeremy Howick, you'd done a paper on, I'll just read it here, an empathy definition at last, exposing the narcissism of small differences. And you're talking, primarily around, I guess, clinical, what you'd call clinical empathy. And I did want to kind of explore, I've been working on the definition, a definition model of empathy, and I call it the Holistic Empathy Definition Model. And I'm sort of comparing it to the common definition out there is the affective, cognitive, and empathic concern model. And I find it just very ineffective, confusing, a kind of very confusing model. So I thought we could just sort of explore definitions and kind of just have a chat about that. So do you want to say anything? Maybe start with like your paper and the intention for the paper and kind of what you found there.
Yeah, absolutely. Thank you. So I would agree. I think the divide between particularly cognitive and affective empathy is really, it's confusing, it's problematic. And that was part of the reason we did the work that we did. So we did a study looking at how empathy is defined. And like you say, we were looking at predominantly clinical empathy, or we refer to it as therapeutic empathy in our paper. Um, so empathy in a healthcare setting. So the sort of empathy that healthcare professionals show for their patients or experience for their patients. And there are many definitions. I think one author's been quoted saying there are as many definitions of empathy as there are authors in the space. So there are loads of definitions. And the general sort of feeling, I guess, up until we did this work was that these definitions are all very different and people have lots of opposing ideas about what empathy in healthcare means. And while, that is the case in some situations, there are people talking about specifically cognitive empathy and specifically affective empathy. What we found through our work, and we reviewed over 3,000 papers looking for definitions of clinical or therapeutic empathy, we found that actually most of the definitions have a lot more in common than they do differ. Um, so that was a sort of motivation for our work, I guess.
Yeah, so what are your thoughts about the affective cognitive model? Because even that's kind of confusing in terms of, what comes under each of those headings. From the research I've been doing, and I've been working on this topic of empathy for maybe 15 years, right? And the foundation of my work has been Carl Rogers, if you're familiar with him, within clinical, he sort of explained empathy within clinical psychology. He would do active listening with his clients, which I think has a lot of overlap with how you're defining empathy. It's just how you're listening to people directly. He would use active listening or empathic listening as sort of the process of how he would listen. And so that's kind of the foundation, of how I define empathy. But the affective cognitive model, like let's say, well, under affective empathy, it seems to be there's two sort of, I see sort of two different phenomenon that get put under there. One is how emotions kind of how we sort of sense emotion and feeling.
Mm.
And is it you just are listening to someone, you're sensing their feeling, or the feeling you feel exactly like they do? And there's a whole sort of phenomenon of what's kind of happening with the feeling and how do we interact with those feelings. And then there's the second part to it that seems to come under that affective model, is that it's your reaction. So if I'm listening to you and I'm feeling distressed, well, that distress is empathy. If I'm feeling, concern, that concern is empathy. So it's sort of a reaction to what happens when I listen to you or sense into you. And that seems, I don't know, if does that seem kind of like the how you see the typical explained what affective empathy is?
Yeah, yeah. So I mean, when we look at it in the sort of healthcare literature, I think it's like you say, the focus is predominantly with effective empathy on feeling the same things as somebody else. So you have that emotional contagion. You feel sad, I feel sad, to put it very
Mm-hmm.
simplistically. Whereas the cognitive is, I understand that you feel sad, but I don't necessarily feel anything. And I think actually the cognitive side in the sort of clinical empathy, therapeutic empathy literature almost goes completely the polar opposite of the effective empathy and says that healthcare professionals shouldn't feel anything um, when they're empathizing with their patients, which our model, our definition kind of contradicts that.
Yeah, so the other part is the cognitive empathy. And what I'm seeing there, the sort of the category, the phenomenon that's under that heading is, one is understanding, that you're sort of understanding, and it's not really explained how that understanding happens. The second is that you're sort of imagining, your perspective taking, you're imagining, so it has sort of an imaginative quality to it. And then there's a third category that's often talked about in that model is empathic concern, is that you through all these different, cognitive and affective empathy, that you have concern for the person, and then the compassion community sort of takes it off into, then it becomes compassion or something like that, or empathic concern. And that's also sort of, I see that as sort of a reaction, a bit like affective. It comes under the affective model. So it gets very confusing. And I just find that the, uh, the, the confusion is really hindering effective progress in, like, I'm trying to build an empathy movement, and to make mutual empathy, a, a shared cultural value. And with all this confusion, it's like people don't know it, what, I don't know what people are talking about. What they, you know, so maybe I just quickly share the model that I've been working on. So I've got empathy, I call it holistic empathy. And it's empathy is sort of a basic empathy of me just listening to you, like Carl Rogers would do. I'm sensing, I'm seeing you're agreeing. I see, you're smiling. I sense who you are, and it's both. And I throw out the affective cognitive dichotomy. It's just you're sensing into someone's experience, and I can maybe you're happy, maybe you're sad, and I sense your happiness. And we do active listening. So we listen to you and maybe reflect back what you're saying, and then you would share more. And just like Carl Rogers would do. And that basic empathy is just kind of foundational empathy, that Carl Rogers had written about. Then having that we can sense into our own experience, with self-empathy, and I was calling that self-empathy. And Carl Rogers, sort of hinted at that, saying that if you listen to someone, that actually supports them in sensing into their own experience as well. So if you're in a clinical setting, the doctor listening to the patient and, maybe empathically or actively listening, that the patient is actually given space to sense deeper into their own experience and share more, maybe about what their medical situation is. And then, so that I call that self-empathy. And then the imaginative empathy is sort of splitting out the imaginative part that maybe comes under the perspective taking and and imaginative components of cognitive empathy. That it's a different phenomenon. It's more that I'm sort of imagining like an actor. I'm imagining, what your situation is, and I can be right or wrong. It's a good, and sometimes that turns into projection. I project that onto you, and it can be inaccurate. So to really have a difference between those two different phenomenon, and then going uh, into what I call the holistic empathy is like if you're in a hospital or in a setting that the level of empathy between all the participants, right, between all the people in that setting, there's a sort of a level of the aggregated empathy. And you go into an environment and it can be very empathic. People are very sensitive, to everyone else. And there's a sense of connection. Where you go into another setting and, everybody's aggressive and you can just feel the difference in a group. So that's sort of the holistic model, and just wondering kind of your take on that model.
Yeah, I mean, a lot of what you're saying resonates with what I've read, the work that we've done, and our model. I think a lot of the sort of components and different aspects that you're talking about map on probably to what we're talking about when we talk about empathy in healthcare. Um, you talked about sort of self-empathy and the idea that sort of listening can help you reflect on what you're experiencing and what you're hearing and understanding. And I think, we talk a lot about that in our model when we think about maintaining boundaries. It's about understanding where you sort of end and the other person begins, and how your experiences or feelings might be similar to theirs or dissimilar. So I think this it sounds like there's a lot of overlap. And I think probably what both models have in common is that you can't separate that cognitive affective aspect of
Hmm.
empathy. They
Yeah.
are inextricably intertwined. So I think, yeah, we probably have that in common.
Yeah, I think that's the big issue is the creating that separation between affective and cognitive. That there, I don't know how that got started. Like, Carl Rogers never talked about that in his work, and somehow the theoreticians I just got too abstract, I find. And so yeah, that's the other part of the model is, Carl Rogers is a clinical psychologist. He just listened to the patient, right, to who, and did that sort of one directional empathy. And what we've done is set the model within the context of an empathy circle. So in an empathy circle is it's mutual active listening. So I listen to you for, a while, and
Mm.
we have maybe 5-minute turns. I reflect back my understanding. I sense into, what your experience is, but then we shift, and then we have small groups, and everyone gets a chance to be heard and to speak, speak and be heard to their satisfaction. So we've created sort of a space of a group that has a high level of empathy within in that group. So I think that's another part that trying to take it out of sort of the abstract and let's put it into the empathy circle, and where do you see empathy happening within that circle? And I think with the clinical psychology, I mean, with clinical empathy you're talking about, is that it would be a doctor listening to a patient, right? Or how do you see that playing out? Let's see, first
Yeah,
to
yeah.
understand.
So I think there's definitely that aspect of it, but I think one thing that characterizes clinical or therapeutic empathy is that it's relational. So it's two-way. You can't just have the sort of doctor listening. It's about exploring and asking questions, the right questions. It is about active listening, but then also it's about communicating, say the doctor communicating what they've understood about the situation back to the patient that they're listening to, checking understanding, and then I guess importantly working with them to come to some sort of next step, some action. So I think there's an element of the listening which is probably sort of similar to Carl Rogers' description of what empathy is, and we sort of talk about that in the sort of paper that we published about the study. But I think it's definitely relational. I don't think you could have clinical empathy or therapeutic empathy in a healthcare setting without that two-way interaction.
Yeah, so it's more the holistic, what we'd be calling holistic, that you're always in a relationship. And that's a lot of, I think that's the other problem I'm seeing with the definition. It seems to be coming from an individualistic point of view. There's always this individual that does the empathy, and they don't talk about that it's a relationship. And just like you're saying with the physician and patient, that they're in a relationship and there is sort of empathy going sort of both directions. Yeah.
Yeah. I think, like if you look back at the history of the word empathy, it does start off with it being like an individual experience. It has like roots in like looking at the philosophy of art, and it's about empathizing with a painting, for example, which is obviously very an individual experience. But I think the way that we tend to use it in conversation, whether that be in healthcare or not, is about our interactions with other people. And I think ultimately that's not an individual experience anymore, is it? It's relational.
Yeah, and I'm just looking here at some of the headings you had in the paper. Those sort of the aspects. That first is you had exploring, that you're exploring through non-judgmental active listening. You've got that in there. Curiosity. So it'd be the physician having that exploring the patient's experience. It would be one component.
Yeah. So it starts off with exploring. So yeah, like you say, it's the practitioner, the doctor, sort of asking questions about the patient's condition, but also about their wider life, so about them as a person, their family, their culture. And I guess the important part to that is that it's non-judgmental. So it's sort of being very curious about the person. And then that then leads into the practitioner developing their own understanding of the patient's situation and their life. So, that might involve trying to put themselves in the patient's shoes, which ultimately does rely on some sort of imagination or logic, reasoning to sort of think about what it might be like to be in that situation. And I think what's important about this idea of understanding is that you don't necessarily need to have experienced the same things or the same feelings as the person you're empathizing with in order to have that understanding, which I think is a common misconception with empathy. And then sort of moving on from that understanding of the practitioner, we try and get a shared understanding between the practitioner and the patient. So this is where the practitioner will say, hey, I've understood this about your situation. It sounds like X, Y, and Z. And it provides the patient with opportunities to either confirm that, yeah, that is how I'm feeling, that is what's going on, or to actually correct the practitioner and say no. And it might be that you need to revisit that exploring stage to sort of work towards a more cohesive shared understanding. And then I think what sort of differs from a lot of definitions, or I guess maybe a lot of opinions on sort of clinical empathy or empathy in healthcare, is our next component, which is the feeling component. So this isn't necessarily about the practitioner feeling the same things as the patient. I think there's probably few of us that want to go see a doctor in a difficult situation and for them to cry with us. I think it's about them emotionally engaging with you. It's about the practitioner sort of having that connection and not being sort of neutral and very clinical and cold. You want them to have felt something. And I think there are a few people that feel nothing when they emotionally connect with somebody and when they're empathizing with somebody. And then that often motivates the next component in our model, which is therapeutic action. So this might be, in a medical sense, it might be prescribing a particular course of treatment, developing a care plan, referring somebody for a particular, treatment or surgery or whatever it might be. But actually, even simpler, it might be, showing somebody that you've listened to them and you've really heard them, and that they, making somebody feel understood and validated and acknowledged. So it doesn't have to be so medical and clinical. And then I guess underpinning all of those things is this idea of maintaining boundaries, which, like I said earlier, is about recognizing the practitioner recognizing the difference between what they understand and what the patient is going through. So I guess it's about emotionally regulating and also recognizing the limitations in how much you can understand. Because I don't know, and I'd be interested in your thoughts on this, whether you can fully understand somebody else, even if you've been in a very similar situation.
Well, I would say in the empathy circle, we say that you'll be understood to your satisfaction. So in the, it's kind of, you don't have to have 100%, like every, experience that you're having that you're understood, but do you feel heard enough? And when we do the empathy circle, people share and they say, yeah, I feel heard to my satisfaction. So, so they just feel satisfied with the
Mm.
understanding that the other person has, or the listener has to them. And within the empathy circle, it's very much about boundaries as well, in terms of there's a turn taking. So it's not like one directional empathy, like, the physician is just not going to listen forever, to the patient, for example, and in the empathy circle, it's the same way. We have timed turns so
Mm.
that everyone gets a chance to speak and be heard. And I think that creates a boundary too. And also in terms of the active listening process, like, I find that when, you're doing active listening, I don't know how much you do active listening, practices, but I find that when someone's sharing, like, oh, I feel really angry, I feel really upset, and I reflect back, I'm hearing you're feeling upset and maybe and even angry. That through that reflection, it helps create a self-other distinction because it's your emotions. I'm merely sharing what my understanding is of your emotions, and it's your emotions, and that helps with the self-other distinction.
Yeah. I think that's sort of really what we're getting at with our maintaining boundaries. It's showing somebody that you understand as much as is possible what they're going through and how they're feeling, but recognizing that you don't need to. And I think particularly in a sort of healthcare setting, there's a lot of conversation around empathy leading to burnout, when actually, there's a huge amount of research that shows the more empathic a practitioner is, they actually have a reduced risk of experiencing burnout. But I think it's a common misconception that the more empathic you are, the more likely you are to burn out. And I think that's because there's a lack of understanding around that maintaining boundaries. I think people think that they need to feel as
Mm-hmm.
deeply as the person that they are with in order to have fully empathized, when actually, like you say, you don't. It's about sort of like naming what you understand and what you hear, and recognizing that that's somebody else, it's not yours.
Yeah, that led to, some of the criticisms of empathy, like the book Against Empathy. The core of that argument, from what I'm seeing, is, that Paul Bloom is saying, you go to your therapist, you're totally a wreck, you're in tears, and then your therapist becomes a wreck and becomes in tears too, right? Or you go to your physician and you're in terrible pain and suffering, and then your physician catches that, and they call that empathy, which is not. In fact, it's a block to empathy, because if you're no longer able to sense into the experience of other, that's a block of your empathy, and so it's yeah, it just creates so much confusion, I think, for kind of lay people, like, what are people talking about? And now there's all these, there's multiple books coming out, about the sin of empathy, toxic empathy. I don't know if you've seen that, and suicidal empathy. So there's a whole series of criticisms. It's coming more from the political sphere
Mm.
about empathy. Even Elon Musk has said, empathy is, the something about the negative aspect of Western civilization. So, but again, I think it's they're criticizing some kind of a phenomenon, and I actually agree that the phenomenon they're criticizing has negative aspects to it, but it's not what I would call empathy. So again, that confusion, definitional confusion, is just leading to a lot of problems, blocks to creating more empathy in the world.
Yeah, absolutely. And we see that in healthcare because people say, oh, we can't. Why would we teach empathy? Because it leads to, people are going to get compassion fatigue and they're going to burn out. But actually, like we've both acknowledged, what they're talking about and what they're criticizing is maybe correct, but that's not empathy. It's something.
Yeah, it's a phenomenon out there. Yeah, but it's not empathy.
No. We really try and emphasize when we're training healthcare practitioners, actually, this is protective for you. This is something that's going to not only protect against burnout, but it's going to increase your job satisfaction. Your patients are going to have better outcomes. It's a really positive tool that you can learn and you can practice.
Are you looking at like with the holistic empathy, I'm looking at how do we raise the level of empathy in all of society. But you have in healthcare, you have like an office, a doctor's office, right? Or a department. And and I would say, what is the holistic empathy level, of that facility? And like how do you raise the level of empathy among there's going to be all kinds of staff. There's going to be the administration, the physicians, the the frontline workers, accountants. I mean, it's just there's a whole group of people working in that environment. And so do you look at that? Like, can you go into a facilities like that, even a hospital, like there's a whole hospital, and
Mm.
can you raise a mutual empathy among all the participants, all the workers in that environment?
Yeah, that's a really great question. So, yeah, a lot of what I've been talking about has been sort of practitioner to patient and how we're sort of developing that in students and also qualified healthcare practitioners. But you're right, I think empathy between professionals is incredibly important. And actually, we also know from the evidence that that's also hugely important in terms of patient safety, patient outcomes, staff satisfaction, and things like that. So yes, we have been. We haven't tackled a whole hospital yet, but we have been doing some work in particular departments in our local area, doing some, I guess, what we're calling sort of empathic team working. So we'll have doctors, nurses, midwives. We're also trying to recruit sort of non-clinical professionals, so the porters in the hospital, the receptionists, administrators, um, so that we get everybody who sort of plays a crucial role in that department together to sort of really enhance the empathy between them. And what we've done has been really successful. But what I would also add to that is I think another sort of sphere of our work is empathy within a healthcare system. So I think it's all well and good sort of we're training people to be more empathic towards their patients, towards their colleagues, but ultimately they need to be working in a system that encourages that and values that. And so we've also been doing some work with sort of leaders of each of those groups of people. So, different healthcare professionals, but also, leaders in terms of administrators, managers, things like that. And getting them to think about what are the sort of systemic barriers to empathy within our organization, in our department, and thinking of ways to overcome those things. And again, that's been really successful so far. So we're hoping to do more of that.
How do you do that? What is it? What practices do to bring more empathy into an organization like that?
Yeah, so it's all sort of driven by them really. So we get them in out of their normal location, offsite for a day, and it's a sort of workshop style training where we get them into mixed groups. So there's got to be different representatives from different sort of job roles in each group. And essentially, we get them to think about what the barriers are, what an empathic system would look like, and then if they, in an ideal world, could make some changes to improve empathy within their organisation at the system level, what would they do? They have to vote on them between themselves. So, sort of group of 30 or so of them will vote on their favourite ones. And then we get them to think, okay, so you've thought in an ideal world what you would do. Are there any of those things that you can do now? And if not, how could we tweak them so that they are feasible to implement? And we essentially get them to commit. Each small group within that training will commit to a particular action that they will be responsible for implementing within the next 12 months. And then we follow up with them over that period to check how it's going. Yeah.
Nice. Yeah, the what do you do much with active listening or something like the empathy circle? Because with Roger's work, his main focus was on active listening with patients, and he did some group work too, and that's what we've sort of focused on. It's sort of a first step. Our goal is to teach everyone in the world how to take part in an empathy circle and how to facilitate one. Because I just
Mm.
think that having those underlying skills just comes in, really, really handy. We just had an empathy summit where we had, practitioners, talking about their experience. And I know one of them, maybe I'll share it with you later. She just talked about, at first she was sort of skeptical. She was at UC Berkeley when we went there, kind of showing the students how to do empathy circles. She was sort of skeptical about empathy circles, like, oh, how can this simple practice, be, very effective? But the more she did it, the more she sort of applied it to more parts of her life. So she started more actively listening with her husband, right? And found that really helped open him up to share more of his experience and deepen their relationship. In work, environment, she found herself listening better to to her colleagues and friends and so forth. And she just did a beautiful, job of explaining just the benefits that come from that simple practice. So just wondering if you use that, active listening or empathy circle in your work.
So we I guess we sort of teach active listening as part of empathic communication and consultation skills. So it's sort of one of our focuses, and I guess that sort of aligns with our model. So the active listening probably should be present throughout the whole consultation, but it probably falls more into that exploring component. So yes, we do. We focus on sort of teaching students, particularly, how to actively listen. Um, but it's not the entire sort of focus. But I agree with you. I think it's, having that skill and, the skill of being empathic in general. I think it extends beyond the sort of the purpose that you're learning it for. So yeah, I
Yeah,
think
it kind of gives you, especially if you're in an empathy circle, you sort of you see the bigger picture of it. Like, hey, I can really apply this in all situations. One thing I've felt that with therapy is it's a one-way active listening. So the therapist is listening to the client, but the client is not learning empathy skills per se of learning how to listen to the other person. Because if they have that skill, they can then take it home in their family and be applying it in their family situation. And I just find that the empathy circle and active listening is core to conflict mediation. I don't know if you do much conflict mediation, but we bring people who are in conflict into an empathy circle. And
mm,
when people are able to slow down, they each can hear each other. They have to, demonstrate that they've heard the other person, that conflicts start unraveling and, people start working through the conflict. So I just find, even for taking it to the next step of conflict resolution, it seems to me like it's a foundational practice. For what you learn, it takes you a long way,
mm.
towards, more empathic skills.
Yeah, absolutely. I think that's really interesting how you said about like in a therapy session, the therapist is really actively listening, but the patient or client obviously isn't always. And a lot of the work that we've been doing with, we're very interested in what patients perceive empathy to be and to mean and to look like. And actually, when you ask them that, one of the key things that comes up is that, yes, they want their practitioners to have empathy for them, but it's also very important for them to have empathy for their practitioners,
Hmm.
um, to understand that they're working in like difficult healthcare systems, and if they're running late, that it's not their fault. They've given somebody time that that person needed, and that you would hope that they would do the same for you. And I think that's really interesting, because I think when we think about empathy, we do, especially in healthcare, we tend to think of it as practitioner to patient, not patient to practitioner.
Yeah, we just want to creating that holistic empathy with all participants, and also that patients take it home, that they can have an empathy circle with their family, right? That there's probably a lot of stresses and strains, and those are things, sort of a mindset that helps with them. And it also, the empathy kind of being heard raises oxytocin level, cortisol goes down. So I think it has a healing. I know Jeremy Howick, he talks about the placebo effect a lot. You're the director of the center there, and I think that's maybe like, it's similar to empathy in the sense that when you're being listened. Yeah, I mean, a lot of times people say, oh, empathy is neutral, right? That if you're listening to someone, it's a neutral thing. But I think it's inherently positive. The phenomenon itself is a positive, constructive phenomenon,
Mm.
because when you're heard, you're having physiological things happen in your body, like the oxytocin going, up, your stress hormones, which are going to cause inflammation and so forth, are going down. So there's a healing aspect to the empathy itself that I think kind of doesn't get understood.
Yeah, yeah, absolutely. And there's such a, there's a huge amount of evidence to support that. We see that patients who are treated by practitioners who are more empathic have lower pain, they have reduced anxiety and depression, lower mortality rates, they have shorter stays in hospital. So I think it's yeah, it does have actual physiological benefits. And I think, like you say, it gets dismissed too much as a soft skill that is nice but not necessary
Yeah, well,
when
I
it.
see it in the compassion community. I don't know, I hear all the time like, oh, empathy is neutral, but taking action takes compassion, which I don't agree with. I think that empathy has a compassionate,
Mm.
not a compassion, it has an active, I mean, that's part of your model, is that there's an active component, that from the insights that you've given, you're taking some kind of an action and it doesn't have to be based on, feeling sorry for the person or compassion necessarily. I mean, it can be just, the empathy itself leads to that action.
Yeah, yeah, and that completely aligns with what we've found. It's, like you said, it doesn't need to be a concrete, like observable action. It's listening to somebody, it's hearing what they're saying, it's acknowledging, it's validating them, and that's empathy. That is the action sometimes.
Are you familiar with human-centered design? Have you looked at that? It's a process that comes out of Silicon Valley, and it's really implemented throughout the whole worldwide design community. So this is the community that designs services and processes. So they just design anything, even, the computer here had to be designed, the software is designed, my microphone here is designed. So how you design any product or service, our whole world is designed, the whole room, somebody was thinking about each and every phenomenon, every item in this room. And, designers, it's their job to, kind of research and come up with product design.
Mm.
And they have a model for human-centered design. And it says, whenever you design, you have to empathize with the needs of the people you're designing for. You have to understand what's going on for them and what their experiences are. And then you find problem areas, and then you create, a question around that problem area. And then you come up with a lot of creative ideas. They have all kinds of processes for generating, a lot of
Mm.
creative ideas. And then you sort of hone in on a couple of those ideas that you think are best, and you create a prototype of that for that idea. And then you go and test it, with the people, and then you're empathizing with the reaction. So it's an iterative process for creating, anything. I think it really overlaps with the healthcare field. that
Mm.
but it's really based on empathy. And the Cleveland Clinic, if you're familiar, have done a yearly conference on empathy and design, and they're like the top one or two, medical facilities in the United States. And they've talked about it's like the whole experience. You walk into a hospital and what's the experience that what does the person feel? Is it, is it an environment that makes them feel calmer, more relaxed, more warm? That, who do they interact with? It's like the whole journey through the medical field. You can design it for the benefit, but you have to understand how people feel. What's the impact of different phenomena going to have on their experience. So anyway, I, 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 I mention that because it shows that you don't have to have, compassion, or so you can just, from a design point of view, good design is based on an action that comes from that design is based on empathy.
Mm. Yeah, I'll have to look into that more. That sounds fascinating. But yes, yeah, absolutely, absolutely. Empathy itself is the action sometimes.
Yeah. So what are you working on now? What's the, sort of projects you have in the works?
Yeah, so we're looking we're doing a lot. We're doing a lot. In short, I guess the sort of main thing that we're working on at the moment is we're developing a new scale to measure empathy in healthcare contexts. A short, simple scale, which is what participants in one of our recent studies said would be desirable for them. They don't want to fill out super long questionnaires after they've been to a healthcare consultation, or if they're a practitioner, they don't have the time. Um, so we're doing that and we're testing that soon. And then we're doing a few systematic reviews looking at how empathy impacts patient adherence to different treatments, and also looking at why empathy levels might change as doctors enter the sort of postgraduate years of their training. So once they finish medical school, what factors might be at play there. Revisiting the link between empathy and burnout, and then also focusing on empathy and how it differs between sort of different diversity characteristics, which is really fascinating. Um, yeah, so
Hmm.
lots.
Yeah. How do you measure empathy?
So we are developing a sort of very short, it's a very short questionnaire to sort of be used, I guess. You give it to a patient after they'd had a consultation with a practitioner and ask them to sort of rate their empathy. So as soon I can share
Hmm.
that with you as soon as we've tested.
Well, with the active listening process, in the empathy circle, we have a test. It's like, do you feel heard to your satisfaction? So that's sort of a test. Like, are you feeling heard? And you say, yeah, I feel heard to my satisfaction. And I know Carl Rogers had talked about the level of empathy within a therapeutic session
Mm.
measures success that the patient is going to have. And I think they they did one test of empathy that I saw where they had like 40 therapists and academics, and then they would look at a recording of someone and then rate how well they were doing. So I'm just thinking in terms of measurements. It's kind of tricky to measure. You have like the IR, what's that, reactivity index or something that, and
Yeah,
it's terrible. I mean, I don't know how you are, but it doesn't measure. It doesn't measure empathy as far as I can see. It's like sympathy, and it's got everything in it. So a lot of the academic measurements that I see out there, it's I think they're kind of useless, but I don't know.
yeah. There are some that are really great, and then there are some that are maybe less useful, and like less aligned with what we actually think empathy now
Mm-hmm.
is. Um, there are definitely some great ones. I think what we heard was that people wanted something very short and simple. So something
Mm-hmm.
that isn't really academic and text heavy, something that really just captures what we all perceive empathy to be.
Have you
And it's
been
very
felt heard to your satisfaction or something? Yeah.
exactly, yeah,
Mm,
you felt that the person was listening carefully to you, that they've made an effort to try and understand your situation and your feelings, that sort of thing, like simple, understandable experiences that
hmm
people have. And I think in terms of like sort of how you measure it, I think if you're getting the opinion of one person, so whether that be the patient or whether that be just the practitioner, I think there's always going to be limitations to the measure, the rating that you've got. So one thing that's been really important to us is that we develop something that the wording can be adapted. So for practitioners, there'll be a version for patients, there'll be a version for students who are training to be healthcare professionals, and then also a version for observers. So that might be family members or carers or educators if they're assessing a student. And the idea will be that you will get multiple ratings, so from the patient's perspective, but also from the practitioner's perspective, and you can sort of match those together and see how they
mm,
compare
hmm
to give you a bigger picture, more holistic picture of what it is that you're looking at.
Yeah, and you also talked about physician burnout. I think that something like empathy circles where the physicians have a chance to talk with each other to share like what are feelings of concern, anxiety, stress, or that you're having, and that they have fellow physicians that they can listen to. Because when during COVID is when we got started with our empathy circle facilitation training, and we got connected with a hospital in Brooklyn where you're just kind of overwhelmed with COVID patients. And with the staff, we did empathy circles, training with the staff there. And they were saying that just that you learn sort of the practice of active listening, and then you can even go for just a few minutes and have someone say, "Oh, can you just listen to me, actively listen to me, for 5 minutes?" And that being able to vent, your
Mm.
feelings, maybe stresses and strains that you have within that, very demanding environment, that would just help, kind of bring down their stress level. And I find it for myself too. And, I have some empathy buddies and I get half an hour just to, talk about whatever's going on for me and it just helps kind of, calm me down or feel more connected and feel less detached. Yeah.
I I need an empathy buddy.
Well, you should join our empathy circle facilitation training. Maybe we could even do some experiments with empathy circles for the healthcare because I was thinking too that like for students, you hear that the empathy goes down for med students. If the med students had empathy circles with each other where they could talk about the stresses and strains they're having, take an hour or something and they just share, or even for a study group that they use empathic listening in a study group. I'm just wondering what effect that would have, on them, so.
That's really interesting. That's really interesting. And actually, when we've spoken to students, they do say that, I think particularly when they go sort of into the clinical placement part of their training and they're seeing all these, really quite traumatic and distressing situations, that actually having the opportunity to sort of, I guess, almost debrief with one another, which
hmm
sounds somebody who's got more experience and has been through those things before, it is really helpful. But that's sort of, it's not hard evidence that we've got there, but it's, anecdotal.
Yeah, well, if you want an empathy buddy, glad to do an empathy buddy session with you, or do it. Maybe we can do some empathy circles. Because I'd love to, see how we could collaborate. We've really been focusing on the empathy circle. There's a lot of other practices, but you can only do so much. And I just see that as it's a building on Roger's work. It's a first step, sort of gateway practice that you get a lot of benefits. And then there's a lot of other practices. For example, I don't know if you've heard of focusing practice. It's so from Roger's work, there's a lot of different tribes or practices that have sort of been built on that. And there's the focusing was created by a grad student of Rogers called Gene Gendlin. and he did a study of different therapy, like what therapy was effective, who had the most growth in therapy, and then he found that what it was is the patient who stayed at the edge of their felt experience of what was happening to them in their felt experience that they would
Mm.
share, and that's where the openings, new growth would happen, is like a new emotional experience kind of, you know, coming into your consciousness, and it changes, who you are. And there's a whole practice called focusing around that. That then you have practices like from Marshall Rosenberg, nonviolent communication, which also he was a grad student of Rogers, and his work is that being able to express your felt experience and the underlying feelings of what you're trying to get to, what's important to you underneath those, which he called needs. So there's sort of that whole practice. So there's a lot of practices, I think, that build on this active listening, kind of tangible practices. But yeah.
Mm. Yeah, yeah, definitely. That all sounds, yeah, all sounds great. All sounds great.
Well, okay. Well, this has been wonderful. I mean, unless you have something else, anything else you wanted to say before we close?
No, 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 it's
Oh,
been great
okay.
speaking.
Okay, I have a lot of fun. I just love talking about empathy and exploring this topic. And I know you spoke at one of our empathy summits, and we have more coming up. So I hope you'll be willing to speak at some of those. And
Yeah,
it's a real delight to chat with you about this and look at the definitions. And so I think we need to get rid of. There's a lot of things we need to do to kind of clarify what empathy is to really be effective. So.
yeah, yeah, absolutely, absolutely. It's great to hear about your work, and yeah, absolutely would love to speak at another empathy summit and to continue hearing about all the great work you're doing.
Okay, well then, thanks a lot. See you later, Amber. Bye.
Bye.